Welcome everyone to this month's installment of our Teaching Value Learning Network webinar. My name is Chris Moriates from Casa Care and from Dell Medical School. And this month I'm pleased to welcome Heather Smith, who's Director of Quality at the American Physical Therapy Association. And so today we're going to really dig into opportunities for physical therapists and really for all healthcare professionals to work with physical therapists to improve value for our patients. I think there are many opportunities for PTs to improve value. And we need to better engage PTs on these types of initiatives. So thank you for being with us, Heather. And maybe you can jump in and share a little bit about some examples that you've seen that have been successful in engaging physical therapists and improving value.
Sure. Obviously, for those of you, hopefully many people are familiar with physical therapists, but we really are committed to restoring, maintaining, and optimizing physical function for patients across the lifespan and throughout many care settings. So hopefully, folks out there are familiar with us and our work. We have many opportunities, I think, to bring additional value in the healthcare system. We function a lot on teams. There are a number of examples I can point to, obviously with the rollout of some of the evidence-based best practices out there, and episodic payment models like the joint replacement model is one area that we're definitely working with physician, nurses, and other healthcare colleagues. We are also working diligently as providers who can really offer a great option for non-pharmacologic management of patients with pain. That's obviously a hot topic with the opioid epidemic, and we're in the process of publishing a white paper around that. Another area that I think we're going to delve a little bit more in today is on early mobility in the ICU, which I think is an underutilized and undertapped area where physical therapists can actually bring quite a bit of value to our patients in those settings. Yeah,
that's perfect. I think, a lot of themes that we've talked about team-based care, working with interdisciplinary teams, comes through this work. So tell us a little bit about early mobility in the ICU, and I think that will help give ideas about how this sort of thing could work.
Sure. Early mobility programs in the ICU are definitely programs that have been long implemented at some of the academic medical institutions, places like Johns Hopkins, Houston Methodist Hospital, but I think in many other just community hospitals, there are just areas where we haven't seen the proliferation of this type of program. Obviously, I think there's lots of reasons why we might not have implemented these programs in those settings. I think sometimes, we think ICU and mobility might be, terms that don't go together,
right.
When in fact early mobility really can improve the long-term outcomes for these patients and help to avoid some of the complications that we know can occur with prolonged immobility, certainly, which obviously goes hand in hand in this setting.
Yeah, I think I remember actually being shocked the first time I saw a patient who was intubated on a ventilator doing physical therapy through the ICU back when I was a resident on 10 Moffitt, actually the CCU at UCSF. Have you seen physical therapy with actually patients on ventilators? Do you do that? Yeah.
Well, I have not done it personally, but I've definitely seen it in hospital settings. It really is, again, I think until you see it the first time, it kind of isn't something that you think would normally happen. But if we think about all of the negative impacts, again, of immobility in this setting on just acquired infections, long-term impacts of muscle wasting and functional decline in these patients, it makes sense that moving these patients around as early as we can, even when they're still in the ICU, really can help, benefit these patients throughout their hospital stay and then beyond.
Yeah. So thinking about it programmatically, do you have some tips, or have you thought through how to implement, or the strategies to implement these type of programs?
Sure. So obviously, I think, in your care setting, in your hospital, there are certain things I think you need to think through. So first of all, just thinking about your organizational culture, doing an environmental scan and what types of clinical practice guidelines are out there, and just, thinking about how you might set a program up in your institution. Again, I think one of the things about physical therapists in the ICU is that they're often not present until these programs are implemented, but they're definitely in your hospital. So, really thinking about and implementing this just as we would do for any team-based approach, thinking about putting together a team of champions. So, you want a physician champion, you want respiratory, you want rehabilitation, so you want your physical therapist in there, you want nursing, so that team can work together and think about when it might be best to come to the ICU and work with these patients, because obviously there's sedation schedules and, just a whole host of other things going on with these very complex patients. But getting buy-in from all of the team members, I think, is certainly critically important. Other things that I think you want to think about is, just start small. You don't have to, if you're in a hospital where you have a ton of beds or, you have a variety of medically complex patients, just think about starting small when you're implementing this type of program. And the other thing that you want to think about too is just maybe doing some preliminary data collection to see what the impact is on function, respiratory data, thinking about potentially what might be different about these patients as they transition out of the ICU and throughout their hospital stay.
And what have you seen as the sort of impetus to start these programs? Has it mostly been led by PTs themselves who say we want to get in there? Has it been, hospital administration that says we want a program like this, or critical care physicians, kind of all the above? What have you seen?
Yeah, I think it's a mix of all of the above. I think, in these really robust ICU, settings, a lot of times different team members, start to think about these problems a little bit differently. And so that solution may be brought forward by a physician champion. It may be brought forward by the physical therapist. Certainly, I think we're all really familiar with some of the pressures of, trying to decrease complications and improve function for these patients so that they can have successful transition, not just out of these intensive care units, but out of the hospital. Avoidance of readmissions, decreasing mortality. These are all things that hospital administrators as well as practitioners are more and more concerned about these days. So I think that drive can come from a variety of places. It's just really very dependent, I think, on organizational culture.
Sure. Yeah. I think obviously that's something we've seen with sort of any of these type of initiatives, no matter, what the topic is. It feels like organizations are so different. And in a lot of ways, as we know from past studies, the culture is not even organization specific, it's ward specific, right? The fifth floor ICU might have a completely different culture from the fourth floor ICU, and oftentimes we find actually more variability between different units in a hospital than even between the hospitals themselves. So yeah, I think that's a challenge we come up against, and one I think a lot about the tension between centralizing something and having centralized tools or things that are generalizable, but also recognizing that everywhere has to do a little bit of innovating for themselves.
Yeah.
So maybe to that point, I was wondering, like, your role in the APTA. What role does the APTA play in sort of helping centralize some of the resources for this?
Sure. And just to give, again, folks a little context, our association does represent over 100,000 physical therapists, physical therapy assistants, and students of physical therapy. And our role, really as an association is to help get best evidence-based practice pushed forward to the frontline clinicians, to really tap into those programs out there that have been successful in ICUs and to identify some best learnings and strategies to help others implement programs like these. As you mentioned, it is always a little nuanced, right? Because, not every organization is the same, and the cultures can be very different in different nursing units in any hospital. I think that there are, again, I go back to things like really getting cultural buy-in from the team. That can have very different looks, from a timing standpoint, from how rounding might occur, just how care planning for these patients might occur. But having those things in place, I think, is really where it becomes critical for success. How they do it, I think that's a little bit more the nuance. Certainly, we're working now at the association actively on two guidelines that will help physical therapists and other providers in these care settings be able to, really look at what is the best evidence in early mobilization for these patients and really identifying other issues that may transpire after a longer ICU stay. And so, pushing those resources out, not just to our physical therapists, but, to patients and families. We do have a patient and family website, and just really being able to work with other healthcare professionals in doing educational offerings like this, just to help professionals know that there are resources out there and these programs do exist.
Yeah, I think that's probably an important example and lesson about, once again, the role of kind of a professional society like your own, and kind of both the limits of what you can do, but also the resources that you can provide. And diving into the project a little more, you've mentioned and many of the benefits, and a lot of them are obvious, right? I mean, we recognize the clear benefit of doing this, but I think you've collected sort of data on this, or at least, have reviewed the literature on it. Maybe provide a little bit more about the real benefits that have been seen, the value for patients in a program like early mobility in the ICU.
Sure. We know, obviously, that there can be a lot of benefits, everything from really improving function. So, I talked a little bit about really trying to maintain muscle strength. And we know that obviously muscle wasting can occur really rapidly in these patients. So that's certainly one benefit. Things like avoiding unintended consequences like pneumonia, pressure ulcers, reductions in those through these programs, really preventing overall neuromuscular weakness and a much quicker path for recovery. And another area that I don't think have touched upon just yet, but, really the cognitive aspects, reducing some of the delirium, complications from delirium, and just, these patients tend to have just better overall orientation because they're actively engaged and able to do more in these settings. So I think that those are certainly some, and as you cited, there are a number of, and a growing body actually of literature about the benefits of these programs.
Yeah, it's fantastic and important work. I guess thinking about sort of the lessons learned from this, what can other organizations, what is needed to sort of accelerate this type of work, to get physical therapists thinking about ways that they can improve value for patients, and to be able to implement programs, maybe outside of PT, if you look at other professional organizations, other healthcare professionals. What do we need, do you think, from what you've seen?
Yeah, so I just think we need to get the word out more. Again, I think that this is something, until you've seen it happen, I think sometimes people are a little shy about thinking about actually implementing a program. I don't want to say this aggressive, but in a lot of ways it is, can be a little shocking for people to think about this happening in the ICU, right?
Yeah.
But then we think about all of those benefits for the patients and the families and the care team, to really be able to accelerate in many ways the, again, trajectory that these patients have with a much speedier recovery. I would say ways that we as an association have been successful at getting these programs pushed out. We, just like many of the professionals listening, right? Lots of you belong to your own associations and go to conferences. Just really sharing your own experiences and talking about these programs will encourage adoption more widely. Not everybody picks up a journal. Obviously, I think journal articles sometimes stimulate us to think about care a little bit differently. But I think just peer-to-peer interactions where we have the ability to talk more about the success of these programs and where folks might find resources. So, I think that is certainly one way that we can really get these programs to be more infiltrated in more hospitals. Again, I know it always comes back to, the administrative benefits and the patient benefits, but I think there's plenty of data that we can point to and talk about that I think all hospitals, are concerned about at this point in time. And, as this healthcare system continues to evolve, we are going to have to think about, more centric patient and family care. And it's going to require us to think more novelly in these team-based approaches for our patients.
Yeah, I agree. I think it highlights the key role to be played with just dissemination and showing, because as you mentioned, it could seem counterintuitive the first time, like I said, the first time you see someone on a ventilator working with physical therapy, it's kind of paradigm shifting. But once you see that's possible, then others recognize, oh, this is possible. We should think about this as well. And it becomes easier for each subsequent group that wants to do this and can spread, but you have to first share those visuals and those stories and the success. Yeah. And I think once you see someone on a ventilator working with PT, you start thinking, wow, there's so much that's possible, right? Like there are things that we thought we couldn't do or shouldn't do that clearly provide value for patients, and kind of shifts sort of the goalpost. There's so much more we could be doing.
Yeah. Well, it becomes a new norm of thinking, right? So, there's many times in healthcare we thought something wasn't possible. And then that becomes the new norm. And then, it does help us to push that envelope a little bit more. And so, those are all positive things. It's just taking that first step and realizing that it doesn't have to be this. I think sometimes people are very overwhelmed. And I would just say, again, small steps, start small. And try to get buy-in, because I think when there is, again, buy-in from the whole care team, it is just so much more successful. And that's true in so many other aspects of medicine as well.
Yeah. Well, thank you for sharing your example and letting folks know about this. Anything, last words you want to say to the group here, which, as you mentioned, is multidisciplinary, includes physical therapists, but also many physicians and trainees and medical students, and just kind of what is the key message you want them to leave with about working together?
Yeah, that's a great question. I think I think the key message here is to just really keep an open mind. And, I think sometimes we make assumptions about what can and can't happen in certain care settings. And I just think, trying to engage everyone at the table to really bring their expertise in to help, elevate the patient care that we can provide in any care setting. I think that's probably the biggest key, is just always looking for that opportunity to make care better and continuing the dialogue. I think in so many instances, I'm always finding that I'm learning so much more about all of my colleagues in healthcare and the things that we can bring to the table. And so I would encourage people to ask questions and think broadly. And, really, I think that's what changes and evolves patient care to a better space.
Absolutely. Couldn't agree more. And I think I really thank you for joining us. And, that's really the goal of what we're doing here, to bring diverse folks with different stories and different examples together to share with our group and set that example. So we appreciate you doing that. And we appreciate all those who tuned in. And please join us every month, third Thursday, hang out for our webinar or podcast where we bring leaders from the field who are teaching or implementing programs that improve value for patients. Next month, we will actually have students from our new Choosing Wisely STARS program sharing some of their examples and what they're doing to help integrate Choosing Wisely into medical education from the bottom up. And so that should be really interesting as well. So thank you, Heather. Thank you all. Have a great month.